We're back with Value Health Voices. This is episode 12, I think, if I have the count correct. Amar, it's great to be back. We have so many episodes planned with great guests coming up, but tonight you are the guest because we're going to talk about the CPT code development process and the RUC, and I couldn't think of who better to interview on that than you.
I'm happy to give our listeners a brief intro and overview of what goes on behind the scenes and how the sausage is made.
All right, let's get right into it. This is a real treat for me. This is exciting because you and we talk about this all the time. I know you know the CPT process and the role of the RUC in valuing CPT codes inside and out. You live it. We're going to talk about a bunch of things tonight, really as an introduction. Hopefully not get too deep into the extremely wonky end. Hopefully we can manage to succeed doing that.
I'll try not to nerd out too much.
There you go. So in doing this, I think the obvious place to start is more general, and then we'll gradually rise the ladder of sophistication and specificity as we go through this. So if we could think about maybe a menu of our conversation tonight, we'll start by, we obviously have to define what CPT codes are. We have to talk about the difference between the aspect of developing the codes and then how they're valued, which is what the RUC does. I think we'll talk about things like the life cycle of these codes, how they go from sort of idea of something new all the way to a category 1 code, just to describe a few things. Other things on your mind as topics to talk about?
Yeah, we can talk about which stakeholders are involved in getting new CPT codes and who are the interested parties who want to get them valued, and what is the composition of these panels, and just some of the behind the scenes workings of practice expense and physician work.
And I think it would be also really nice if we can take some time as we work through this to talk how people who aren't necessarily actively involved in the process, like you as a RUC advisor, and we'll define what that is, but stakeholders, like you said, physicians, hospitals, industry, what role does industry have in what comes before these important policy or rule, let's call them suggesting bodies, because ultimately CMS either accepts the recommendations or does not. And finally, maybe we'll talk about how this process that currently exists today might change in the near future, right? There's always discussions about what the future may look like within the next
and maybe
few years.
Some of the criticisms of the RUC, and I'm happy to talk about some of that as well, because obviously nothing's perfect, so
that's right.
We can definitely get into that as well.
All right, so if we're going to follow our plan and start general and get specific, let's start at 30,000 feet. What exactly is a CPT code, and why do they matter?
The CPT codes are codes that are owned by the AMA, first of all. So they are codes that describe all the medical procedures that doctors do. And when I mean procedures, I mean anything. So let's say a doctor sees somebody for a consultation. There's codes associated with that, depending on how complex that consult is or how much time was spent. So there's CPT codes associated with that. If you're a surgeon and you're doing an appendectomy, there's codes with that. If you're a radiologist and you're reading a chest x-ray, there's codes with that. For cancer, there's codes with our radiation therapy treatment delivery. So anything any doctor does has a code that they can bill, which is owned by the AMA. But those codes then also have value. If they're considered a category 1 code, then they have a value associated with it. And that value can then be converted to a dollar amount, which is how physicians get reimbursed.
We mentioned a couple very basic abbreviations there. We mentioned AMA, that's the American Medical Association, and they play a fundamental role in all of this, as you already intimated. What does CPT stand for?
CPT stands for the current procedural terminology.
And I do not know why that is what it stands for, but just for the sake of facts, we got that out there. So, all right. So CPT codes change all the time, and this creates some frustration on the part of clinicians. It's why people who are coding and billing experts have to stay up on these things. Why are they added, deleted, revised? What's going on there?
Sometimes new codes will come from stakeholders who want a new code, right? So let's say there's a new technology, and then industry could potentially ask for a new code, or the professional society of those physicians practicing that new procedure, they can ask for a new code. And so a code change application is initiated for a new code. But also, if you want to modify or edit an existing code because you no longer think the work that's done for it accurately describes the work that's being done now, then you can maybe modify or edit a code. That also can go into a code change application. Or if something's no longer being done and is outdated, you can request a code be deleted. So those are all mechanisms for new, modified, or deleted CPT codes.
And that is the responsibility of the so-called CPT editorial panel. Is that right?
Correct. So the CPT editorial panel is a panel of 17 people. Majority are physicians of different specialties, but then there's also some other representatives on it, like from payers, CMS, Blue Cross Blue Shield. So you have other representation on it, but ultimately it acts as an arbitrator of what the specialty societies or industries submits with their code change application, and they'll deliberate whether something should be a new code or not.
I was recently talking to some junior physicians, some trainees, and I think actually one of the folks was just out of training, and they had by that time come across the term CPT code, but they had no idea really that this was there was a distinct body responsible for all this. And I tried to explain that both with this panel and then the RUC itself, which we'll get into, there is an enormous amount of influence over the entirety of the US healthcare system. Did I oversell it or get it right?
No, it's 100% true. This is where some of the criticisms are, because a lot of this happens behind closed doors. And the reason for it is there's a lot of confidentiality that has to be part of the process, obviously, because otherwise people wouldn't be honest and transparent if they felt that their information could be public.
With this as a good intro, we can start to get into that interplay between the CPT development process and then handing it over to the RUC, which is the RVU update committee. But before we hit that point of handing the code over, could you tell us a little bit about the contents of the submission? Let's say the package of evidence that a sponsor must put forward to when requesting a new code. We can talk through that and then talk about the code going over to the RUC.
Sure. Yeah. There's a lot of stuff that can go into that application. So it's a long application we fill out. I mean, I'm talking like it could be 20 something pages long, and they'll ask everything under the sun. So pretty much some examples would be, is it FDA approved? Are there other codes that are currently being used to bill for this procedure? Other codes do you think could and would still be billed with this procedure? What's the clinical evidence? What's the prevalence of the disease being treated? How widely is it performed specifically in the United States? What's a sample clinical vignette, we call it, or a scenario of a typical patient who would be getting this procedure? How often do you think it'll be performed? How often has it been performed? So there's so many, and that's just the tip of the iceberg that I can think off the top of my head.
No, that's right. Yeah, this is not something that happens on a whim or quickly, that there's code changes or new codes that arise. One of actually thinking about that conversation I had with my junior colleagues the other day, I remembered another thing that one of them asked me. She asked me, can just any doctor or any person sign up and attend the CPT meetings, or how does that work? Is that not open to the public?
I believe with the CPT, it is open to the public, and you can request to sign up in advance and attend. You just would have to sign a confidentiality form. I believe that's the case with the CPT.
Got it. So you can't just turn up, but you don't have to be anybody special. You have to sign up, and then you're good.
Yeah, I think you'd have to sign up and register, and then you could attend. You're not allowed to speak at this, but you could attend as an observer.
Mm-hmm. Good. All right. And so in that, let's say, sequence of questions, my next thing I really wanted to ask you is, okay, so you've submitted all that packet. A CPT code now has born. It exists. What triggers it to be handed off to the RUC now for valuation? Or tell us a little bit about that process.
Well, and actually, even maybe I'll step back one more thing. So what triggers it to be, let's say, approved by the CPT? So the thing they're really looking at is the level of evidence. And so what they really want to see is what we call level 2A evidence at a minimum, or level 1 evidence, meaning randomized control studies, or at least a systematic review of cohort studies. They don't want to just see some smaller studies that are level 3 or level 4 studies. That does not rise to the level. And they want to see a few of these, usually about 3 or more studies. The other thing is they want to see that a lot of these studies were done in the United States, and it wasn't just all European data that's being collected. So once all that's presented, they look at this, the application, and they'll discuss it at the panel, and then they'll vote whether to approve it or postpone it or deny it. So if they vote to approve it, then is when it goes to this whole thing you were saying with the RUC. And so one of the things they'll do is they'll send out this level of interest, an LOI, and they'll see what medical specialties societies are interested in this new code and would be interested in being a part of the valuation process.
Yes, I've seen those. And at this stage also, in addition to the LOI, if I have it correct, this is where a lot of the industry folks, the specific companies that are moving a code forward, a code application forward, seek guidance from the specialty societies, right? They reach out and have a kind of conversation about evidence development. Do we have enough? Should we take it forward? Do I have that right?
Yeah, so they'll do it before the panel meets. So before the application's submitted. Once the application's submitted, you're not allowed to have any of these discussions with industry. But prior to that, because they want to get the opinions of who we call the CPT advisors, which are the people from each professional society who are the experts and the representatives of their specialty, and kind of are there at the CPT meetings representing the specialty with these code change applications. So the vendors will ask, do you think we have enough evidence for a category 1 code? A category 1 code are the ones that end up going to the RUC to get valued. Or do we think if there's not enough evidence, then we may sometimes recommend as a professional society that it meets the level of a category 3 code, which means it can be used and documented, but it's not going to be valued by Medicare and CMS. That doesn't mean that private payers, you can't negotiate some rates with them, but it's not going to be valued by CMS.
Sure. And the other, I'm glad you brought up the specialty societies at this stage, because that actually is a third thing that I remember was brought up in this conversation I've referred to a few times now. And that is, so if I'm coming out of training and I'm interested in health policy, and I believe this particular physician is a pediatrician, what is my avenue to get involved? And I did say to her, I said, well, the specialty societies have a key role to play in all this. And so they likely have a committee or a subcommittee that you can essentially apply to be on to take you forward through this, let's call it a health policy track. Is that right?
Yeah, no, you're 100% right, Anthony, because actually the AMA pretty much mandates as part of this process, because they want to have stakeholder involvement from members who are practicing in their specialty. So they mandate that a specialty society has some form of advisory committee for both the CPT and the RUC, with CPT advisors and RUC advisors. And they may name these committees differently. Some will call it a health policy committee. Some will call it an economics committee. Some will call it a code development and evaluation committee. But whatever it is, it will always sit in a professional society and be an avenue for people who are interested in health policy to join that committee and be a part of this process.
Right. And it is in that capacity that you participate in this process, and then me too, but obviously much not in the hot seat like you were, but instead sort of learning the process. So, all right. So we brought up the RUC a few times. I even spelled out what the abbreviation RUC means. So let's talk about that now. Where do you want to start talking about the RUC?
Yeah. So let's talk about what the RUC is. So the RUC, like you said, is the Relative Value Update Committee. It's also part of the AMA. It's 31 people who sit on this committee, and they're nominated and then elected to be on this committee. And they are supposed to be independent of whatever specialty they came from. So let's say you have a pulmonologist on there, you have a vascular surgeon and everything like that. When pulmonology or vascular surgery procedure codes come to the RUC, they are not supposed to advocate or even frankly, be a part of the discussion, because they're supposed to be impartial and just independent and not represent their specialty. But that being said, then there's this advisory committee, like I said, on the professional societies, and those advisory committees would nominate a person who serves as the advisor. So I'm the RUC advisor for our professional society, the American Society of Radiation Oncology. And so it's my job to represent radiation oncology interests. So when I go to this panel, I sit, like you said, in the hot seat, and they grill me and ask me all these questions about a new procedure or whatever's coming from the CPT panel to the RUC.
And of course, being in the name of the committee, the Relative Value Unit Update Committee, they have to calculate how many relative value units, how many RVUs is associated or assigned to each CPT code. They have to make a suggestion, actually, to CMS. And so it almost seems silly to me to ask you this question, Amar, but is it possible in a succinct way to describe how the RUC calculates the RVUs for a given code? At least maybe the categories of valuation.
Yeah, exactly. It's totally doable. Let's try this. Okay. So there's this LOI that goes to the professional societies. Let's say they're interested in the code that's coming out of CPT. They'll mark their level of interest as a level 1 on the LOI, which means they are going to survey for that code. So what does that mean? They will send out surveys to all the members of that professional society and say that this is a sample clinical vignette. And so how do you believe this code is in terms of a relative value? So is it similar to other codes, or is it more, should it be valued higher or valued less? And they look at that based on time and intensity of the work. So that goes out in the surveys. The other thing that goes out in the surveys is practice expense, which is the cost associated with delivering that care. And that practice expense can consist of equipment, it can consist of supplies, but it can also consist of clinical labor staff and the time for, the clinical labor staff for those procedures. So all this data is compiled together from the surveys and comes back to that advisory committee that you're a part of, Anthony, at the professional societies. And we compile it all together and create recommendations from that on what we believe is a physician work RVU based on that time and the intensity of that work, as well as a practice expense RVU based on the practice expense associated with that. And we submit those recommendations in a summary of recommendation to the RUC and to the practice expense committee that's a part of the RUC. And then we go there and be in the hot seat and answer questions they have about that spreadsheet we submit.
Oh, that was outstanding. So yes, the time and complexity weighs heavily, as you described. I was just thinking through some examples in my head. Just like you, I'm a radiation oncologist by training. You're the chief of a radiation oncology department. I'm one of the hats I wear is also chief of a radiation oncology department, but also the medical director of a larger cancer program. So meaning, all the specialties, med-onc, surg-onc, rad-onc, et cetera, and thinking about the different RVU levels for some of the codes I see that come across my desk. So complex oncoplastic reconstructions, enormous RVU numbers, nasopharyngolaryngoscopy, which you probably do, I do, because I take care of head and neck cancer patients. And it's, a few RVUs because it takes 2 minutes and is really simple. Just as a
exactly. And if you
huge example.
100%. Like if you think about it, like the intensity of a procedure where you're operating, let's say, against the spinal cord, like a spine surgeon or a neurosurgeon, it's going to be much more intense than, taking an X-ray of a foot or something, And so that is, everything's relative. So the key is nothing is thought of in terms of absolute when it comes to valuing physician work. It's all relative. And this is, one of the criticisms is, around the survey data. Like, how do we know the survey data is accurate? And, what happens if people inflate their times or inflate the intensity? Then are we, reimbursing more highly for these procedures than they should be?
That's just inherent in that process. And if I remember correctly, you and I spoke at length about this in one of our episodes, specifically the origin of this relativity in valuations and why and how that flows to essentially this idea of a fixed pie, that if something gets more RVUs, something else gets less, as a kind of a balance. And we talked about why that is.
Right. And actually that feeds right into the whole RUC process because you have a fixed pot, like you said, and as CMS calls it, budget neutrality, right? So there's only a certain amount allotted to the Medicare physician fee schedule. And so when you come with a new code and you're trying to seek evaluation and you're sitting in this hot seat, any service that gets valued highly has to come at the expense of somebody else's service. Something else will end up going down with budget neutrality. So it was a very clever system that was created with the AMA and CMS. So you have a lot of people all the doctors are fighting amongst themselves between this fixed pot of money to justify why something should be valued more than something else. And so it stifles innovation. That's one of the other criticisms.
That's a big criticism there's a criticism that I believe has persisted ever since the origin of the RUC, and that is about the composition of proceduralists versus non-proceduralists. Talk to us about that. I think a lot of our listeners are going to be interested in that.
The RUC, as we mentioned, has 31 individuals on it, and there's a select number, I believe it might be 21 or 22, who are elected by professional societies that are designated to have a spot on the RUC. And then there's a few rotating seats, I believe 4 rotating seats. But by and large, those specialties that have a permanent seat on the RUC are a lot of them procedural specialties. And so that does shift the balance about when we look at valuation toward, valuing things that may be procedural higher. I mean, that's one of the criticisms. The CMS actually, recognizes this. And so one of the things they've done in recent years is to allow for primary care to be valued higher. They purposely took back all the non-procedural CPT codes, like the consultations and follow-ups that primary care does, and revalued them through the RUC process, kind of forcing the RUC to revalue them, looking at increasing clinical labor pricing for nurses involved and changing the time and complexity. So this way it allows for primary care to, bill for like those more complex services. But by doing that, actually in the last couple of years, it's procedural specialties that all of a sudden now took the hit because of budget neutrality. So
there it is again. So I was, thinking about the relationship between the RUC and CMS. We sort of glossed over this and took it for granted, but just to be really specific, at a certain point in time, the AMA essentially convinced CMS that AMA should have essentially the sole contract, the sole responsibility for the functions of the CPT code origination and then code valuation. But what they didn't get as part of that relationship with CMS is any kind of promise by CMS that CMS would accept always the RUC's recommendations. So how often does CMS just say, hey, thanks, RUC, but really we think you're off base here with this recommendation. We're going to go our own way.
Yeah, I mean, it actually doesn't happen that frequently, but as you are a radiation oncologist like I am, we know it's happened in our field. Almost 10 years ago when we were revaluing treatment delivery, where the treatment delivery codes for radiation therapy went through the CPT process, got approved, got surveyed, went through the RUC process, evaluations were created, and they were approved by the RUC, and then it went to CMS. And CMS said no. And because, these previous codes, once they go through this process, the old codes get deleted. So they couldn't just go back and say, well, we'll just use the old codes. So CMS created new codes called G codes, which they own, and just said, we'll just make them, we call it crosswalked, but in other words, they're just, the valuations could be tied to what the old codes were. And the reason for that is they also hear feedback from a lot of stakeholders. So patient advocacy groups sometimes have a stake in the game. And let's say a breast cancer society group may say, well, we think our, codes to treat breast cancer should be valued higher. And so they have input. Or if the ranking of the valuation for, let's say, a level 1, a level 2, and a level 3 procedure, if they think the ranking is wrong, then they may just reject all the codes outright and say, no, we think there's a rank order abnormality, they would call it.
Right.
And so that would also allow for codes to be rejected. But it's not that common, but it definitely happens.
Sure. And you mentioned earlier the obstacles to innovation that come from the requirements of budget neutrality. Are there other things? I mean, I remember at the RUC, there were vendor applications, or let's say vendor-driven codes, not code applications, but codes that were up for valuation at that particular RUC meeting. Have you heard, and sort of being in the scene, what folks on the commercial side, the vendor side say about the process? Is it too complex, too long, too much bureaucracy? What are they saying? Anything to that regard?
Yeah. So back in the day, it used to be that most of the code applications all came from the professional societies, but the process has been, they believe, so slow with allowing for this new innovation. So many times now, industry will hire their own consultants who are experts in the CPT RUC process and try to push an application through themselves. The problem is the way that the CPT RUC process sees it is, even though you can do that, and sometimes it is successful, typically they want the specialty society to at least support it, right? Because the specialty society, the RUC advisors, are the ones who have to advocate for it at the table. Industry is not allowed to have a representative there. In fact, as a physician, me, myself, for example, I'm not allowed to have any conflict of interest at all. It has to be very clean, because they don't want somebody to have a stake in the game financially and then advocating for something clinically. So that's why industry is not allowed to be there, or any physicians involved in industry. But one of the things that with the industry recently is also the level of evidence, right? So the bar of evidence has been kind of raised than what it used to be. It used to be they would allow for more data from Europe, or maybe not so much randomized control data. So by having that requirement, it also is tough for industry to they're trying to sell the equipment, they're trying to sell the product, right? And so if there's no reimbursement for it, it's very tough for them. So many times now, instead of going through the CPT RUC process, they'll try to bypass it completely and just negotiate with CMS to get codes outside of the CPT RUC process.
Okay. To get G codes, essentially.
Well, yeah, HCPCS codes, they're called. But yes, G code is a type of a HCPCS code. But yeah, they're pretty much codes that CMS owns that allow for new technology. And
yes, you pulled out another code category altogether. And just for listeners, the HCPCS code is actually HCPCS, and that stands for Healthcare Common Procedural Coding System. And yes, you brought up the difference between a code that is the AMA's own CPT code versus a code that comes from CMS directly. So, all right. So we've covered a lot of ground. I wanted to ask you, go ahead, Amar.
No, I was thinking other thing I think would be interesting for our listeners to know is, like, what is the dynamic that actually happens at the RUC? So it's very stressful because you're in this hot seat. I equate it to like giving almost congressional testimony or something like that our listeners may see or recently.
I agree with you. That's what it was like. Yeah.
Yeah, exactly. So you're there and they'll grill you with like question after question. You could potentially be at that table for 3 hours, 4 hours, no break, and you can just have your glass of water and they can just grill you with one thing after another. And when I mean grill, like, for example, a long practice expense, they may say, well, why do you need 2 pairs of gloves? Can't you do this with 1 pair of gloves? Why do you need a motorized table? Can't you just do it with a regular table? Why do you need 2 drapes? Can't you do it with 1 drape? So it's down to that level of minutia where they'll ask all these questions, So yeah.
You bringing that up makes me laugh, because that's where I started to ask myself some questions like, can there really be any accuracy in this? I mean, we're asking that level of detail. How does that play in real life? Right.
Right.
But it's a system we have.
Yeah. And what they really want to know is it typical? Right. That's the question they'll ask. It's not, can this be done? Is this typically done? And obviously they rely on the opinion of the experts. So you'll typically have an expert in that procedure at the table also who says that, no, this is typical and not an anomaly. But that is one of the criticisms for sure.
So throughout this conversation, but especially over the past minute or two, you were talking about criticisms. And I think those criticisms, some of them do have a good foundation. So we're starting to hear reform ideas circulating, ways to change the CPT and RUC process as it relates to transparency or broader stakeholder seats, even replacing the RUC altogether. So what are we talking about here? What are we hearing?
Yeah, I mean, like I said, there's pluses and minuses. On the one hand, there is a lot of criticism, and it's coming from all avenues, whether it's the administration or whether it's, there's economists, healthcare economists who write a lot about this and have published extensively on this, and whether the RUC just needs to be scrapped altogether and a new system needs to be created. The thing I worry about, and the reason the RUC came to be to begin with, is because it allowed for physician input, right? It allowed physicians who practice this and do this to explain why it should be valued the way it is. And so I think no matter what the new process is, my fear is that if you take physicians out and it's just, what do you call them? The counters.
The bean counters.
Bean counters. Yes. If you just have the bean counters doing it, that's the worry. Like, will things actually still be valued correctly? Now, obviously this is not 100% accurate what we do, but I will say they do try to at least allow for accuracy. For example, when they look at time or intensity, they don't oftentimes go with what's the median value. They usually go with what's the 25th percentile. And that's because they're assuming that maybe these numbers that they get back from the surveys are inflated. So you would actually really have to explain really strongly and heavily and have a good argument why something should be valued higher than the 25th percentile. They also have specific times that are associated with things like dressing a patient or gowning a patient or cleaning a room or, that type of stuff, which you would really have to explain why something should take longer than it does for like everything else in the house of medicine. So they try to have these package times and look at 25th percentile. But that being said, no, there is definitely a movement to scrap the RUC altogether.
Sure. And so as we bring this to a close, I'm going to ask a question now that I'm also going to answer, but then I want to hear your answer too, because I think you don't have to be as expert in this as you are to be able to answer this question. And that is, you think about some advice for health system leaders who've never followed a RUC meeting. What advice would you give them? And the advice that, as I say, I'm answering my own question here, that I found that I had to give some people is that they didn't even have an idea that the RUC existed. Maybe they heard the term at one time or another, but they really didn't know what it does. And I say my advice would be, you got to dig in and understand, because this is one of the most powerful committees in the entire US healthcare system. What do you think?
Yeah, I agree completely. It's shocking how little many hospital executives know about this.
Flies under the radar.
Yeah, and even when I talk about it, I can tell that they think they know where physician reimbursement comes from, and they think a lot of it is maybe through MedPAC and some other channels, but they don't realize the whole CPT RUC process and, like you said, the critical role that this one committee plays to set these valuations for CMS.
And I'll make just one other comment here, if I could, and that is that the role of CPT codes and the role of the RUC is so deeply rooted in healthcare finance in this country, the U.S. healthcare system, that I do not think there's going to be any easy or simple on-ramp or alternative in the next 3 to 5 years. Am I reading that? Am I having too much confidence in the status quo?
No, I mean, I think I agree with you. I think it would just have to be, new payment systems entirely, right? So like whether they're bundled payments, other kinds of alternative payment systems would have to be created that go outside of this kind of building block model, right?
Sure.
So it's just kind of valuing a service in entirety for an episode of care. But yeah, for new technology, and there's just too much vested interest from all the different stakeholders to just abandon it completely.
Sure.
I think the only other, go ahead, Anthony.
I say one thought about some of these alternative payment models, bundled approaches, is that at least there'd be some runway, and I think pretty long at the outset of these models, where the expectation from CMS would be that clinicians, hospital operators are still billing these codes, still doing the things like they did them pre-bundled model, to allow for a kind of apples to apples comparison and a kind of, let's say, backsliding away from the sort of the way things were done. Because if you had a given, I don't know, pathway of care and set of services you provide, and now all of a sudden there's a bundle, well, one thought could be, well, I'm just not going to do stuff I used to do because now there's not an individual reimbursement widget for that. And so I think that the CPT system would persist for some time, even under a bundled model, just kind of running in the background.
Exactly, to value the new technology that's coming in that's not part of the bundle, for sure. I think the only other thing I want to leave the listeners and viewers with is the amount of work that goes into this from the volunteers' perspective, the physician volunteers, right? So you've been a part of this process now, Anthony, and you've seen some of it, and it's it always is tough for me when I hear other physicians complain about like, oh, there's so many cuts and this is going on and why is it happening? And I'm like, well, there is people who are advocating and trying to make sure it doesn't happen. But a lot of it comes down to people filling out the surveys. So when people get surveys, people should be filling them out, not just letting them sit in their email box, because it's the individuals who submit the feedback that's where the valuation's set from. So people have to fill those surveys and then appreciate the amount of hundreds of hours that the physician volunteers on that committee are putting in to help everybody in the greater, good.
Right. And maybe a thought I'd leave everyone with is just harkens back to a comment I made earlier from talking to junior doctors, and that is get involved. If you have a passion for this and you care about health policy, you should get involved with your specialty society, learn about this process. It could be very rewarding. And like Amar, you may find yourself carrying on your shoulders the weight of an entire specialty in front of the RUC one day. And it's a great and awesome responsibility. So thank you for doing that. And thank you for answering all of my very basic questions
Anthony.
tonight.
This was definitely a different flip of an episode where I was the guest, but we'll have you be the guest one day too, Anthony.
I'll have to come up with.
Promise I'll give you payback for this.
We'll have to come up with something that I am qualified to answer, like you are for this. But this has been a lot of fun. Like I said, it was a real treat for me. You shared a lot of your knowledge, and I hope that our listeners find it interesting. And we're going to be back, like I said, with a real guest next time.
Yes.
For our next episode. So, all right, very good. Thanks, Amar.
All right, thank you.